Have I got one for you? Here we go.
So Pratik, you're next week as well, isn't it?
Yeah.
Yeah, all the best. Yeah.
Thank you.
All right, Pratik. So we've got a 50-year-old male. He's been in a road traffic collision. We've done ATLS. These are his scans. Let's say we're going to take him to theatre. All right, everything else is done. Anaesthetist, ICU. We've decided that we're going to take him to theatre and we're going to reduce this and fix it with an ACDF. Okay, so tell me about your approach.
Okay, so I'll divide my management in the theaters. I will divide it into first is the patient positioning, because this is bilateral facet dislocation. So I will be very careful with the patient positioning. There will be, in terms of positioning, I will put a sandbag under the scapula, the head end up by 30 degrees, neck extended, rotated to the other side. I prefer doing it from the right side, so the head would be slightly rotated to the other side, making sure that there is no increase, there is no neurovascular deficit. And if there, I will be very careful. If there is any neurovascular deficit, I will be stopping it there and then. I will position the image intensifier, checking, doing a level check. My incision will be a transverse incision at the level of the 6-7 cervical vertebra. The extent would be from the midline to the posterior border of the sternocleidomastoid. Skin, subcutaneous tissue, and the investing layer of the deep cervical fascia is the first layer. Along with, I will ligate the external jugular vein, which comes laterally. Following this, my plane of dissection would be on the lateral side. It will be the carotid sheath, including the carotid vessels, the vagus nerve, and the internal jugular vein. On the lateral side, it will be the sternothyroid and the sternohyoid muscle. Following this, at this time, I will ligate the superior and the inferior thyroid arteries, which will come in the field. Following this, I will have the so the sternothyroid and sternohyoid goes along with the pretracheal fascia. Next, I will encounter the esophagus and the trachea dissected medially. Following that, I will have the prevertebral fascia. I will incise the prevertebral fascia, making sure that the longus colli muscle along with the sympathetic trunk are taken off from the bone and dissected laterally. And I will come onto the vertebrals, onto the anterior surface of the vertebra. I will reduce. I will do the discectomy. I will then followed by reduction. If the reduction is achievable, then I will fix it with a cage and plate. If the reduction is not achievable, then I might have to consider a few reduction maneuver, which involves hyperextension. If not, then I have to preliminary, I will fix it anteriorly, temporary fixation, make the patient prone, and remove any block in reduction posteriorly, fix posteriorly, then again come back in the anterior position and do the definitive fixation in the anterior position.
Okay, that's good, Pratik. Definitely a high pass from me. I don't think I had anything else. I agree with your positioning.
Traction.
Yeah, you said you were going to go on the right side. It doesn't matter which side you go on. I tend to go on the left, just because of the recurrent recurrent laryngeal nerve. But it doesn't matter, provided you have a reason why you're going one way or the other. So these are landmarks. So your mandible is C2, your hyoid is C3, your thyrocartilage is C4, C5, your cricoid C6, which is where you were going to go, and then C6 to T1 is down here.
Do we need to mention this in the approach, or is it okay to just?
I think in that one where you can say, I think it was C5, wasn't it? So I think you can say, look, my landmarks would be the cricoid at C6, because that's going to be the most palpable. And probably the thyroid cartilage for that one. If you're going to go higher, then you should probably mention the hyoid. But then you said you were going to check with II. I would probably double check with II when you get down to stripping off the longus colli as well. So you talked about superficial fascia, platysma, external jugular vein, around the neck, split around SCM and trapezius, the pretracheal fascia, which is continuous with the carotid sheath. Your superior and inferior thyroid vessels run from the sheath to the midline, and they're the only structures that are passing medial to lateral when you see them in your approach. And in some ways they do restrict your access, but you can ligate them. Prevertebral fascia, and of course the sympathetic trunk runs on its surface with the stellate ganglion a little bit lower down. So this is the diagram that you need to know. So it just describes, so it shows here how we've got the strap muscles, the thyroid, trachea and esophagus retracted one way, and then we've got the carotid sheath and the sternocleidomastoid the other way, so that we can come down onto the prevertebral fascia, which overlies the longus colli muscles and the anterior longitudinal ligament. All right, so this is the diagram that you need to remember in your head when you get asked about this approach. What else have I got for this one? Yeah, so this is the technique, and you basically talked through this, and this is what you need to say. All right, so your thing is, you can do a transverse incision. You got better cosmesis because it's within the line of the fibers, but if you need to do multiple levels, like say you've got a myeloma or something with multiple vertebrae that you need to fuse, then you're going to have to go with a longitudinal incision for multiple levels. You split the platysma in the line of its fibers with your finger. I think you said that. Identify the anterior border of SCM and incise the fascia longitudinally. Take it laterally. Retract the strap muscles, the trachea and the esophagus medially. Expose the carotid sheath. And this is the bit that I got grilled on in one of my exams. Actually, this part of this approach. So you want to develop this plane. That's why I put a bit more detail. You want to develop the plane between the carotid sheath and midline structures, so that you can retract the sheath laterally with the sternocleidomastoid, to take it that way, like in the diagram.
So can I just quickly ask one thing? I mean, this pretracheal fascia and the carotid sheath are continuous, I think.
Yeah. So you need to incise them.
Okay. And petechial fascia comes medially, and the carotid sheath with its content goes laterally.
And that's the point that I got asked a lot in my exam. Exactly what I was going to do with the carotid sheath. So this is what it says. Superior and inferior thyroid arteries, they're the entry structure, go medial to lateral. And then you basically need to work medially and go gently because you're going behind the esophagus. And then, as you said, down onto the prevertebral fascia in the midline. Make sure you stick in the midline because you've got the sympathetic chain over the longest colli on each side. You split it longitudinally on the anterior longitudinal ligament, and then you dissect it subperiosteally. And this is the only thing I would do different, particularly, I'm sure you do it, is when you get down to the actual vertebrae, I would probably put a needle in the disc and just check my level. That's the only thing I'd do differently. Dangers. Recurrent laryngeal nerve. So the injury rate reported in ortho bullets is 2.3%, and there's no difference between the right side and the left side, which I think is why we say it doesn't matter which side you go. On the right side, the recurrent laryngeal nerve is a little bit more variable and runs a little bit more of an anterior lateral course than on the opposite side. So it's slightly more vulnerable, which is why I go on the left. On the left side, the recurrent laryngeal nerve is slightly more protected, but you've got the thoracic duct on the left side. So that's, you know, it's your choice, whichever one you want to go. But there's a risk to everything you know, there's a risk with everything we do. So that's your recurrent laryngeal nerve, thoracic duct, C7T1, your sympathetic chain, Horner syndrome, your carotid sheath. Any of these big red, blue things is going to be bad. All right. Vertebral artery, inferior thyroid artery. And the other thing that you can mention is that if they develop a post-operative retropharyngeal hematoma, you need to decompress them because they can get airway compression. All right, I think that's it for the Smith-Robinson approach. Any questions?
It's made up of a femoral device and an acetabular device. On the femoral side, that's composed of a stem, and that stem has a part that's in the diaphysis and the metaphysis. Then it has a neck with a trunnion, and then it articulates with a ball. That ball is typically made of metal or ceramic. On the acetabular side, you have...
Fantastic. So obviously we've got lots of surfaces here. Tell me how they interact with each other.
The surfaces, okay, of this looks like an uncemented device. The surface is therefore based on friction and a press fit that interacts directly with the bone. That can either be partially coated or uncoated, depending on the hydroxyapatite, which will encourage ingrowth, osteoconductive, and osteogenic. On the interaction between the trunnion and the ball, that's again a friction, a torque surface due to the trunnion's differential shape. That can be based on the difference between the proximal of the trunnion and the ratio to the distal end. That articulates on the inside with, again, a friction fit with the inside of the metal head, which is symmetrically shaped.
And when we talk about interactions, we're talking about tribology. Now, what is tribology as such?
Tribology is the study of how materials interact with each other through friction.
Is it just friction?
It's through friction, and I guess it's the study of how surfaces interact with each other in motion that includes friction and lubrication.
Okay, and so we know that. What's more important for us as orthopedic surgeons?
Lubrication and how much wear there is at the implant interface.
What is wear then?
Wear is the loss of material due to motion.
Is it just that, or are there other ways of how it can happen?
Wear can either be chemical or mechanical, and I can talk through those types of wear.
So tell me about mechanical then.
Mechanical can be divided into abrasive, adhesive, and subsurface delamination. Abrasive wear is when there's different types of wear there, when there's asperities which interact with each other and break off parts of the material. And that can be due to 4 types of wear. And I can talk through those. Alternatively, first body wear is when 2 implant interfaces that are designed to interact wear out. Second body is with an implant that's intended on one surface but non-intended on the other side. Third body wear is when you have a loose body, for example, between 2 surfaces that are interacting. And fourth body wear is when 2 non-intended surfaces are interacting.
Okay. So tell me, in terms of your experience, how has this affected your work?
Where has affected my work, particularly related to hip replacements in terms of reasons for revision. For example, when we're choosing implants, we want implants that have low wear and high fatigue strength, low fracture risk as well, and implants that are working under their endurance limit. So, for example, my preference is to use in active patients a ceramic on poly interface. That's because that's designed to have low wear. Ceramic has low friction, and highly cross-linked polyethylene has extremely low wear with some compromise with fatigue and endurance.
Okay. All right, I think that's probably exhausted that one. It can be quite a dry topic, to be honest, where Drivology, as I say. So yeah, so you are part of that structure. So how do you think you went with that, Kartik?
I took some. I was trying to work out where to go with it. I think I knew the answers. It's just I need some advice as to how to get on with it. Yeah. So it can be quite a difficult one in terms of they'll probably lead you along in some of the basic science ones. What I would suggest is try and preempt them. So if they they'll give you a little clue. So anatomy of a hip replacement. They'll want to talk about the interaction between the different surfaces there. Yes, I gave you an uncemented one, but normally you'll get a cemented one because they also want to know about the interaction between the cement and metal interface as well. So there are all these different surfaces they want you to go through. But actually, from overall, you were good. You were very good. You knew the answers. You had you did need a little bit of prompting to get some things across, but that's fine. Minimal prompting is all right. So from my point of view, very safe pass. But obviously, we're trying to polish it up. So yes, tribology, the science that deals with the interaction between surfaces and motion and the consequences of that interaction. They do like their definitions. So try and be a little bit more precise with your definitions, and where progressive loss of a bearing surface as a result of mechanical or chemical wear. Now, mechanical wear can either be removal of material from the surface by mechanical action, so abrasive, adhesive, fatigue, and electrochemical. I didn't want to go too much on that. I'll come later. So galvanic, fretting, pitting, corrosion. But the examiners will push you on to get everything. But I was very pleased. You talked about abrasive well, talked about adhesive well. And fatigue, we'll discuss a bit later as well. Then also in terms of modes of wear in the joint arthroplasty, how it can be done. You talked about motion primary between 2 bearing surfaces, the expected, the motion between bearing surfaces with a secondary non-bearing surface, i.e. head rubbing against the back liner. So try and involve a bit more sort of experiences in terms of clinical application of it. So basic science, they want you to go. It can be a very dry topic. They want you to move on sometimes onto the more sort of clinical side. So if you can apply a basic science scenario in a clinical scenario, that's what they want. That's pushing you towards a 7 and 8. Okay. And obviously third body wear, sand in the shoes, for example, or 2 non-bearing surfaces rubbing against together, trying it in the head. Again, that's a big thing at the moment in particularly in arthroplasty. So if you can push some of that in, that's a good example of you understanding that you've got this good core basic knowledge and you're applying it in a clinical situation. That way, that's pushing you from that 6, hopefully towards a 7 and an 8. Okay? Does that make sense, Kartik? Absolutely. Thank you.
Is there any questions you'd like to ask?
No. Again, it was just I was trying to give the examiners and you some points, and I was hoping you just tell me, okay, talk more about that. Otherwise, I'd have gone 10 minutes into chemical and galvanic corrosion without getting any points. So is that appropriate to stop, offer, and then back off and then wait?
Yes, as I say, sometimes what will happen, if there's a gap, don't make it too long a gap. They will want they may want you to move on. But yes, I was happy you stopped because I wanted to move on to different subject. If you're carrying on, don't worry. They may interrupt and say, "That's great, that's fantastic. Can I just ask you about this?" Or "What can I pick up on? Can I pick you up on this?" It's not necessarily them prompting you. It's just them. I was happy with your answer, and I was trying to move you to get you to score more points. So the anatomy, describing the hip replacement, that's the starter up bit. That's the relax, warm you up, because everyone knows what hip replacement is, hopefully. or else you're in the wrong exam. But as I say, they always have a relaxing question, and then to warm you up, and then they'll push you onto it. The meat of it was was a good understanding of what wear was, and also a good understanding of the different modes of wear. As I say, the way how you can now improve that answer is applying it in that clinical scenario, so that you can show and demonstrate that you will think, because we're all supposed to have learnt this as part of our first years of being an orthopaedic registrar, but it's how we apply it as an orthopaedic surgeon. But yeah, in terms of, you did talk quite well when you're talking about the type of implants you want to pick up on as a hip surgeon, for example. Okay.
Thank you.
And that sometimes could be another question. All right. So we'll move on to the next.
95 minutes. So, how each of these images created? What do you see here on the right? Start with the top one.
So the top one is a coronal image of the knee joint. Is then an MRI scan of T2 weighted, because the fluid looks bright.
Okay. So what's an MRI scan? What's one of those?
So MRI stands for is a magnetic resonance imaging, which uses a superconducting magnets and radio frequency impulse to create an image. So this uses the principle of each atoms in our body has got the hydrogen atoms, so which is responsible for these images. So the tissues which consist of hydrogen atoms, it responds to these the magnets. So when the tissue is placed onto the magnets, what happens is so before that, the atom has got two functions. So one is it to spin along its axis, and the another function is as a precision. So when it spins, it also wobbles. So when the tissue is placed onto the MRI scanner, the atoms becomes longitudinally aligned, and once the radio frequency impulse is given, it is transversely placed, and the time taken from the transverse alignment to the longitudinal alignment, about 67% is T1, and then the remaining is T2. Based on that, we'll get a T1 weighted and T2 weighted images, and again in T1 weighted images and the TR is a repetition sequence, is both the repetition sequence and the echo sequence are shorter, and then the both are longer in T2 weighted images. And also we got a different sequences. It's called a spin echo sequence, and is the most commonly used. And also there is a metal artifact reduction sequence, which is used in metal on metal. Yeah, so, and again, there are some potential advantages and disadvantages. The advantages being no radiation, no ionizing radiation risk, but the disadvantages is claustrophobic and again, yeah.
Okay. So if we move on, what about the second image? What's that?
This is an CT coronal image again. So again, the CT scan is an imaging modality, uses a radiation. So it's basically it uses a multiple X-ray sources, and it has got a detector on the other side. So it's kind of a collimated the X-ray source, and then the detectors also it's receive in other direction. So instead of patient moving, so here it just circles around the patient, and then we get a 3D picture. And also the difference between the X-ray and then the CT scan is the multiple X-ray sources has been used here, and then the and also the soft tissue, and then the bony delineation is better in the CT scan.
So, soft tissue, to use soft.
No, it is not used to delineate
soft tissues in CT.
Sorry, I meant that the CT scan is not meant for soft tissue details. However, when compared to the X-ray, because the X-ray, so the X-ray images are produced based on a high beam, low beam, and attenuation. But here, the CT scan will give a good delineation of bony details, and that nicely separates from the soft tissue details.
Okay, so you briefly mentioned attenuation. What do you understand by that?
So the different tissues in our body, it's differentially absorb the high energy electromagnetic radiation. So based on that, we will get the images. So the high beam attenuation means absorption is high, and the low beam attenuation means absorption is low. Okay,
are you aware of it? Is it measured using any units?
It is measured in, I think it's millisieverts.
So about the attenuation, not the amount of radiation.
Oh, sorry. Sorry, I'm not sure about
That's
the
okay,
units.
no problem. That's all right. And so, yeah, when would you use a CT scan? When would you typically order a CT scan? What kind of clinical situations?
Yeah, so the CT scan is useful to delineate any articular fractures, and then and also this provides a 3-dimensional picture instead of 2-dimensional pictures and X-rays. So for the preoperative planning.
Perfect. I think that's your time. Your time's up. Your 5 minutes is up. Good. How did that go?
Yeah, I think it started well with MRI scan. Probably the CT scan a little bit stumbled. Probably.
No, I think overall you did very well. Yeah, it's one of those questions, isn't it? You know, you kind of learn it once upon a time, and then you've got so much to learn. It kind of goes at the back, but it's useful just to keep refreshing that. So your MRI, you know, you mentioned everything. Can you hear me?
Yeah, I can hear you.
So I just got a message. My internet's unstable, so I'll just make sure I cut out. Okay.
No,
so yeah, MRI is good. So you mentioned everything that I wanted you to mention about. You spoke about the strong magnetic field and the radio frequency accelerated pulse. So you've got your atoms spinning, and then when they line up with longitudinally, don't they? Then you apply your radio frequency pulse, and they transversely, which is what you mentioned, and their precession also all lines up at the same time. And then you mentioned about T1 and T2. That's good. So so T1 is the relaxation time, isn't it? So the T1 relaxation time is from when it goes from longitudinal magnetization to and it recovers 63%. You mentioned 67%. So 63% of the normal once the radio frequency is stopped. And T1 is good for anatomy, isn't it? It's good to show you anatomy.
T2 for pathologies.
Yeah, T2 is for pathology, isn't it? So and that's the time from the transverse when the transverse magnetization vector decays by 37%. So it's 63 and 37. So yeah, good. You mentioned about the image that you saw, that water's dark on T1 and you use T2 because it's brighter. And you're aware of the fat suppression. I think you mentioned the stir sequences and the Mars sequence as well, the metal artifact reduction sequence, which was good. Also throw in there the use of contrast, such as gadolinium, enhance edematous tissue on T1 weighted. So that's something extra to throw in, which is very, very good. So MRI. So always useful to know about uses, advantages and disadvantages. It sounds very basic, but it's always important to make sure you know. And obviously, as we know, it's good for soft tissues, occult fractures, malignancy. It's good that it doesn't have any ionizing radiation like X-ray or CT, but it is expensive, can be claustrophobic for patients, and obviously you've got some precautions, having your pacemakers, ICDs, and cardiac and brain clips, etc., and cochlear implants. That's something that they're disadvantaged about. CT, again, I thought you did well, actually. You know, I think the only thing you need to really know about is the Heinz-Field units.
Yeah,
you
the
know,
Heinz-Field, yeah.
Heinz-Field units of attenuation. So
Yeah.
just that water's 0, and then you've got bone is 1,000, and then air's minus 1,000. So, you know, so water's in the middle between air and bone. And there's that's the, you know,
Yeah.
the mark of attenuation. So when you knew about that, you're able to describe how the modern CT scanners have developed. You know, you've got the helical, the spiral CTs, isn't it? So as well as it rotating, the gantry, you've also got the actual where the patient, you know, the couch for the patient also moves. So it's not just the gantry moves, but they both move together. So it speeds it up even more. Now, it's also useful to throw in, you know, because, you know, how is that different to an X-ray? Well, you know, you've got pixels and voxels. So, you know, so 2D is a pixel, but then when you've got a volume of tissue, the depth, that becomes a voxel. So that's by definition. You know, so from the actual images, it then creates 3D image, and that each one of those volume of a pixel is called a voxel. Yeah, so these are little terms. So fan-shaped X-ray beam, tissue attenuation coefficient, collinear detectors, pixels, voxels, you know, these little terms to throw in. And obviously the disadvantage is it's, you know, it's radiation, isn't it? So, you know, that's the disadvantage. So you've got to make sure you use it appropriately. But it's got massive advantages, like operative planning for non-unions, unions, deformities, complex fractures and triarticular fractures. You use it all the time, don't you? And then it's also useful to know about, you know, co-registered images with PET scans and things like that as well. That's the advantage as well. Good. I think that's 5 minutes of feedback. So what do you see here on the right?
So this is a plain radiograph showing a mid-shaft fracture of the femur, which has been treated with an intramedullary nail.
Okay.
So intramedullary nail is a load sharing device.
Is it always a load sharing device?
Not necessarily. You can't put compression across it in case of like a hindfoot nail.
So if it's not a load sharing device, what is it?
Load bearing.
So when, you know, when might it be a load bearing device?
Like a total knee replacement with
No, as a nail, when you're using a nail.
Like if you have like a comminuted area,
okay,
and you want to maintain the length.
Okay,
or
so
in case of cancer,
area would become more of a load bearing, isn't it, rather than load sharing? In this situation, what concept is applied here?
So in this situation, the concept is load sharing.
Yeah.
So there is bone-to-bone contact at the fracture site.
Okay.
So yeah.
Good. What do you understand about working length of a nail?
So the working length of a nail is the nail which the part of the nail which is free from being in contact with any surfaces. So for example, in this case, the screw at the bottom and the press fit at the fracture at the isthmus is the working length at the distal end, and then the proximal end is from the other screw to the or even the metaphyseal area where it's attached to the fracture site.
Okay. So when you ream the femur and you have a really tight fitting nail, where's the working length there?
So in the tight fitting nail, it's from the screw, from the locking screw to the area of the isthmus. So
No,
where
but
it-
where's the from the distal screw?
From the proximal screw to the isthmus, and isthmus to the distal screw. So that'll be the working length. Where
Are you sure?
so the area of contact with the bone could be more than just a point. So the surface area where it is attached, from the distal end of that surface area to the locking screw at the bottom.
Okay, no problem. We'll come back onto that, but just to cover more things. So, do you use solid or hollow nails, and what's the kind of difference between them?
So I use hollow nail. The difference is that the strength of the material is stronger with the same diameter nail for the same material, but the flexibility of the nail is reduced when you use a solid nail. So the risk of breakage is higher, and also ease of insertion is better with a hollow nail. There is also the moment of inertia is also better with hollow nail because the difference between the inner and outer diameter nail, which helps.
But okay, if I can just stop you there for a second. So, but obviously a more solid nail of the same diameter as a hollow nail. Surely this solid nail will be stiffer than a hollow nail.
Yeah, so
the
it's
same
solid
diameter and length.
Yeah, that's true. So the solid nail is more stiffer, and therefore it's more there's the elasticity of the nail is reduced compared to bone. So therefore there's a mismatch of the elasticity between the bone and the nail is higher with a solid nail. So a hollow nail would give you a bit more flexibility, relative flexibility.
Okay. You mentioned about, I think that's 5 minutes up, isn't it? Okay, right. We'll just move on, go through things. How do you think that went?
I don't know if I was clear with the working length actually.
Okay, fine. We'll come on to that. Yeah. So so load sharing and load bearing, it depends on what you're doing, isn't it? So
yeah,
so just kind of be clear about that and don't get too fixed with, oh, nail has to be load sharing. But it depends, if you've got a significantly smashed up femur and you're bridging it with a nail, well, it's not quite bearing, isn't it, anymore? Sharing, sorry, it's more, it's going to be bearing more, isn't it?
yeah.
So you just have to be careful. It's a concept, not as kind of it's not a device. It's concept, isn't it, of what's happening?
Correct. Yeah.
Mechanically. So that's one. The second thing with the working length, I think so. If you've got no isthmus contact, then the working length, fair enough, is between the two screws.
Yeah.
But if you've got a lot of contact in the isthmus, you've reamed, you put a big nail in, the biggest you can, then the working length is the contact area there, nothing to do with the screws.
Oh, okay.
Okay. So that is your working length. So that's important to just bear in mind with the working length of a nail. So, that's why you want as much contact in the isthmus. One, you put a bigger nail, just stiffer. Two, you've got as much contact, bony contact as possible as well. Is that clear?
Yeah.
So, in a ream nail, when you ream it in a tight isthmus, like in this case, you can see actually the working length is quite short, and it's within the isthmus because there seems to be a good amount of contact.
Yeah.
For example, in an elderly patient that you nail their proximal femur, you know, if they've got a reverse oblique fracture or whatever they might have, and you nail it, they have quite a capacious canal, don't they? And the working length in that situation is between the hip screw and the distal locking screws, isn't it?
Correct. Yeah.
So that, you know, that'll be working length in that situation. But in this one, it's slightly different. Right, coming on to the next thing about solid and hollow nails. What do you think this was sort of probing about? What do you think this sort of was trying to tease out of you?
Is the difference between a hollow nail with the two diameters and the solid nail with a single diameter?
It's talking more about the sort of second moment of inertia, isn't it? Principally.
Yeah.
And understanding that together with, you know, polar moment of inertia as well. Now, when the nail is, the whole point is, it's like bone, isn't it? The whole point is your second moment of inertia measures the cross-sectional distribution of material from the center. Okay.
Yeah.
So it's the amount of material outwards, and so you think, well, okay, there's not much material in the middle, it should be less stiff, etc. Should have less bending stiffness and torsional stiffness, but actually with the same material, because you've distributed it further away, it's better than a solid nail, because in the middle that material doesn't have much resistance to bending or torsion.
Okay.
And that happens in biology, doesn't it? As we get older, our bones
become more hollow and
they get bigger, don't they? More load is distributed further to try and compensate for the structural deficiencies as we age, to try and give us a stiffer bone, and that's what happens. Okay, so this is talking about second moment of inertia, which, you know, for a hollow nail and a solid nail, I've not put the equations here, but it's pi r to the 4, isn't it? Which is different for a hollow nail, because you need to subtract the radiuses of the outer circle and the inner.
correct.
You know, to be absolutely accurate about the actual second moment of inertia of a hollow and a solid nail. So the second moment of inertia it's also known as an area moment of inertia, and that's regarding bending stiffness. But you've also got polar moment of inertia, which is talks about the torsional stiffness of the nail. So that's all about the you know, the torsion rather than the bending. So they're both, you know, they're forces, but in different planes, aren't they? So it's just important to understand those principles, because that's what they'll be getting at, and trying to sort of come at you from a different angle, and just, you know, trying to you know, see whether you understand the differences between the two types and those two principles, you know, the polar moment of inertia and the second moment of inertia as well.
Yeah. Thank you.
Is that clear? So I think you just need to revise that a little bit and just clarify that a bit in your head, because it's easily confused when you sort of heat a battle, you know, in the exam.
Yeah.
Is that all right?
Yeah. Thank you.
Okay. Right. So I think
Thank you.
I've got,
I think
is it James?
There's one question more, if you don't mind.
Yeah.
Just Kartik, I think, wants to
Thanks,
ask or make a comment. Yeah. Go ahead.
I'm actually a bit confused about the working length. So I know that the working length is the length of unsupported bone, but if you ream and then you put a nail in with good isthmic fit, you mentioned that the working length is therefore the length that's got isthmic fit. If you have a better fit nail, wouldn't there be more bone contact and therefore a bigger working length by that definition?
So your area of contact is, where is that really going to be? It's not going to be proximally or distally in the metaphysis. It's going to be in the, because that's the tightest part of the femur, isn't it? You know, whenever we look to nail a bone, we always look at the isthmus. You know, how tight is that going to be? Am I going to put a nail down there? Because that's going to be the tightest bit. So really, that's going to be where your contact area is. So you're reducing.
Why does the definition change? Because it goes from working length is the length of unsupported bone to suddenly the working length being the length of supported or contact bone.
So your working length in the where there's no contact is between the two areas of support, which is the two screws either end.
Yeah.
Because I think, is it Ramachandra or someone like that, they kind of keep, you know, they just talk about that. But in a nail, unlike in a plate, it's quite straightforward. It's just between the two, you know, screws either end of the fracture site is the working length. But in the nail, you also have the contact within the isthmus. So because that's going to be, you know, that's going to be taking some of the support in the actual area of contact in the middle of the bone, the isthmus. Is my my take on it.
So therefore, the working length is the area between unsupported bone minus the area of the isthmic fit, and therefore you've reduced the working length.
Yeah. So that's yeah. So that's my understanding on it.
Thank you for that. Thank you.
All right. Tell me about bone grafts.
So bone grafts are used in orthopedics, either in a trauma setting to encourage fracture healing or for significant bone loss, or occasionally in the reconstructive setting for arthroplasties, or occasionally for adjuncts with tumor repair. They can be allograft or autograft. The benefit of autograft is that there's no risk of blood-borne transmission. They, depending on what that is, it can act, it can be live blood cells, so they can have osteogenetic properties. But the disadvantages is that there's donor site morbidity and only a limited amount of material. Allografts, on the other hand, you can in theory have infinite material. That typically is processed bone, so it's not live bone, so it's not osteogenetic, and there is a theoretical risk of blood-borne disease transmission with that. You could also get xenografts, but we don't typically use those commonly. In terms of allograft processing, there is a stepwise progression how we process allograft bone. That can be, firstly, patients are screened for high-risk behaviors and blood-borne virus checks, and any pre-systemic diseases such as cancer usually makes them ineligible. The donor bone is then devoid of any soft tissues. It is irradiated, it is washed in an antibiotic, an ethanol-based wash, and then it's processed for packaging. You can have different types of, I guess, how bone grafting can work. So you can get osteoconductive, inductive, and osteogenetic.
Yeah,
So
tell me about those.
osteoconductive is essentially a scaffold for bone to grow into and can give some mechanical properties. Osteoinductive has some of the growth factors which encourage bone formation. Osteogenetic has living bone cells which are capable of producing bone, and can also have mechanical properties as well, depending on if that is a cortical or cancellous grafting. And then I guess there's difference of how bone grafting is incorporated by the body. So you can have cancellous bone grafting, and this undergoes a process of creep substitution. So when cancellous bone grafting is used, there's a hematoma and an inflammatory phase similar to early bone healing where there's vascular ingrowth. You then get this creeping substitution where the body's osteoclasts remove the cancellous bone grafting, and a new osteoblast trabecular network is laid down, and that results in a higher strength of the bone over the first few months, and eventually that bone is completely replaced by the body. Whereas with a cortical graft, there is no creeping substitution. There's a transitory weakness in the bone over the first few months, and whatever bit of cortical grafting I can't quite remember. The alternative is a fibulari, a sort of a vascularized bone graft, and that essentially heals like a fracture would, with endochondral ossification at the limits of the bone graft itself.
Okay, what kind of factors would affect bone graft incorporation?
So these could be thought of either as donor, the recipient bed, and the systemic condition of the patient. So the donor, whether it's a live osteogenetic graft or whether it's a processed osteoconductive or inductive, and or it's an allograft or autograft, could influence the turnover of the bone. The bed, if it's well vascularized, if there's any infection, and then the I forget the third one. I guess the overall mechanical environment can influence it. And systemic conditions, sorry, so if the patient has smoking, diabetes, poor managed comorbidities, could also influence that bone incorporation. Yeah,
okay, good. That's 5 minutes. So how do you think you did, Jamie?
Yeah, okay, a few bits I wasn't that slick with, but I guess it's one of these ones that you could talk for 5 minutes, which...
Yeah, yeah, and that's just what I let you do, because, you know, I think provided you're talking, you know, you're ticking the boxes, it's all fine. So this is from Ramachandran, which just goes through the different, so you could be asked, you know, what's the difference between osteogenic, osteoconductive, osteoinductive? You could be asked that. And then you kind of touched on this, the advantages and disadvantages of the different types of bone graft. As you say, xenograft we don't really use. Keel bone, I had to just look that up actually. Apparently it's calf that's been treated with hydrogen peroxide and then acetone or something. But as far as I can see, all the studies are from the 60s, 70s and 80s, and that doesn't incorporate. But that's in the most recent edition of Ramachandran, so there you go. The other way this question could go is you could talk about bone graft substitutes, but I'll save that for another thing. Now, there was only one thing I was going to pick you up on. Yeah, when you were talking about cortical graft incorporation, so it incorporates via cutting cones to incorporate the graft. So you have the cutting cones which go in first, which is why you have that initial loss of mechanical strength. And then you then get the new bone formation, and it grows in that way, followed by the blood vessels, and it's incorporated. Okay,
thank you.
Vascularized grafts, yes, you mentioned that. I was going to come to that. Factors affecting incorporation, as you said, systemic. So all the smoking, diabetes, all of that stuff, the mechanical environment of the graft itself, and the quality of the host bed, as you said. You need cells in the host bed, which might be deficient if you've had some kind of radiotherapy, or if you've had a previous infection, or if you've got poor vascular supply. So, you know, if you've had a massive open fracture with all the soft tissues stripped and you then try and graft it, you might not, graft might not incorporate as well as it could. And if you've got an immunocompromised host. So, yeah, I think you covered everything there that I wanted to cover. You just described osteogenicity, conduction, induction. So, yeah, again, I think you've all done really well on this section. There are some questions.
This picture, okay, what can you see?
Okay, so I can see this is a picture from the clinical picture from the volar aspect. I can see there is an attempt of repair of possible tendon injury in the little finger, and This is a zone 2 injury of the flexor tendons, and that is between the attachment of the FDS tendon on the middle phalanx.
So you can see a extended little finger when other fingers are flat, and you suspect a tendon injury.
Yeah, right.
Yeah. So what I can see is extended little finger, and I suspect there is a flexor tendon injury. All right.
Yeah.
So how would you assess injury to tendons?
Okay, so the injury to the tendons I will assess by I will assess the tendon injury itself. I will assess the neurovascular status, and I will assess the joint which are crossed by the tendon, and also if there is any collateral injury in the form of bowstringing, signs of bowstringing that point towards the
okay, how do you know whether tendon is ruptured or not?
Okay, so I will perform the tenodesis test that will be passive and active, passive flexion and extension of the wrist for seeing the extensor tendon, flexor tendon injury. If on extension of the wrist, the fingers will curl, that means that the tendons are intact. In the passive flexion of the wrist, they should extend. If not, if they remain flexed, that means there is extensor tendon rupture.
All right, and any other way?
I will perform the individual test for the tendons. So, like I will if there are two tendons passing the joint, I will exclude one tendon at a time and then assess the other tendon. Like in the FDP and the FDS of the fingers, I will exclude for testing the FDS. I will exclude the isolated by not allowing the FDP to contract to look for the FDS tendon rupture.
So how you are going to do that?
So, for the FDP tendon that is attached to the base of the distal phalanx volar aspect, I will stabilize the finger from the middle phalanx and ask them to flex the finger. So I'm basically testing for the FDP. For the FDS, because it has got common belly, so if I block the flexion of the rest of the FDS tendon, FDP tendon, FDS tendon, I will be able to isolate the function of the assess the FDS of the middle finger by blocking the rest of the tendon.
So what has the common belly?
FDP has the common belly.
All right. Okay. So you are blocking FDP so that you can see FDS.
Yeah.
So this FDP, FDS is a disturament profundus you're talking about, isn't it?
Flexor disturament profundus.
Are they arranged? How are they arranged?
Okay, so the FDP are the most deep tendons, so they are arranged in a single row, and the FDS tendon are arranged. The third and the fourth tendon is more dorsal, and the second and the fifth tendons are more volar, and they are arranged in 2 and 2 stacks of.
So the flexor disturant superficial standard is superficial to flexor disturant tendon, isn't it? And all the fingers, are they in same plane like FDP, or they are in different plane? The FDS tendon, all the FDS tendons, are they arranged in one plane or different plane?
So yeah, so that is what I said. I mean the second and the third FDS, or for the second and the third, second and the fifth finger, they are arranged volarly, and the third and the fourth they are arranged dorsally.
So if the FDS tendon is more volar to FDP tendon, how does it insert on the proximal phalanx?
Okay, so at the level of the PIP joint, the FDS tendon, they split and they form a camper chiasma, and they go on to insert on the middle of the, and underneath the FDP tendon passes under the camper chiasma.
Okay, so that's fine. So this is a tendon injury of little finger, is torn both FDP and FTS. Okay. How would you repair tendon? Can you tell me the principle of tendon
repair? Yeah. So tendon repair, especially in the zone 2, should be repaired as soon as possible because there is such a high chance of adhesions, poor blood supply, and poor results, and immediate rehabilitation should be sought. The principles are to get 4 to 6 core sutures, which is with the non-absorbable sutures. The tendon end should be handled delicately, and the core sutures should be we should get the core sutures at least 8 to 10 millimeters across the cut ends, and they provide 80% of the strength to the tendon. And then this is followed by epitendinous circumferential sutures, which provide 20% of the strength. They are mainly to tidy up the repair and to allow for the easy gliding. Also, I have to take care of if there is any nerve injury, I will repair it with the 80 or 90 proline, and there should be.
Have you done this before? Nerve repair?
Yeah.
Have you done it yourself?
Yeah.
You've done it, okay.
Yeah.
That's fine. So you repaired the tendon, okay, with core and epitendinous suture. Okay, what else you're going to repair?
So I will
repair the sheath.
I'm not get. Yes.
Repair the sheath, isn't it?
Yeah, repair the sheath, and I don't know. I'm just blocked out at the moment.
You repaired the tendon, okay.
Yeah, to prevent the bowstringing, I have to take care of the pulleys as well.
Yes,
So especially the
pulleys
A2 and the A4 pulleys, I have to repair them. If they are completely damaged, I will repair them with the FDS tendon.
All right, okay. Okay, you're going to reconstruct it with the FDS tendon.
FDS, yeah. I'm going to reconstruct it.
So you've done the repair, okay. What position you want to keep the hand?
So there are two, basically the flexion.
Orthotics are not yet involved. You are in theater now. You repaired the tendon just now, and how are you going to keep the?
I'm going to keep it in the Edinburgh position, and blocking the extension. And Edinburgh position, that is the extension at the PIP, at the interphalangeal joint, and the flexion at the MCP joint, to allow for the maximum extent of the collaterals, maximum stretch of the collaterals.
Okay. All right. This is basically you're keeping it in that position. Where you're going to put slab, dorsally or volar?
So I will put the slab dorsally to start with, but I will institute an early range of movement that will be.
So you're going to refer into hand therapy now.
Hand therapy.
What is the principle of hand therapy?
So the principle of hand therapy is to get active extension as soon as possible, and then the passive flexion can be by the splint assisted or by the patient assisted. So the idea is to get an active wrist extension in case of flexor tendon repair, and the patient or the splint assisted passive flexion.
Okay, you have to prevent the overstretching of tendon, basically, isn't it?
Overstretching, yeah. So yeah.
What can be the complications of the tendon repair?
So there could be various complications like adhesions of the tendon, or there could be re-rupture of the tendon. There could be quadriga effect. There could be contractures and repair failure, as I already said. And,
what is the quadriga effect?
So whenever one of the tendon is repaired or as a result of trauma, it heals in a more contracted position. Then while making the grip, that finger will contact the palm first and lead to the inefficiency of contraction.
So which tendon should be tight to get quadriga effect?
So the tendon which is repaired, that will be more contracted, and it will contact the palm first. And
it is palm first, isn't it? Okay, that's fine. You've done well, Pratik. Okay, just needs a bit tidying up. So first thing, when you are, I told you last time also, when you see the like photograph like this, okay, why don't you tell, you say that right little finger is kept in attitude of extension. I think there might be tendon injury. You are actually giving a lot of information to examiner and making yourself clear by just saying few words like this, rather than just saying it is like this, I can see scar. Okay. Then your answer is assessing tendon injury is first inspection. Okay, there'll be abnormal posturing like you can see in this case. You assess the active contraction of tendon that you have demonstrated, and passive tenodesis, that also you have told me. How a tendon placed, you are quite good, but you could have told it in a much easier way, I think. Like at the level of the wrist, the FTP are at the same plane, FTS are arranged in this, sorry, cannot see, this attitude, okay? Principles of tendon surgery is first, a traumatic technique. It can be done under anesthesia or wide awake. First, you repair, could give 4 to 6 core sutures, okay, and all around give epitendinous sutures, all right. Repair the sheath, okay, and place the tendon in a position of protection and refer to hand physiotherapy, which actually give. There are various protocols. Okay, I don't know, but basically they allow the flexion but prevent the extension. Okay, prevent the stretching out of tendon. All right, complications, you can say there are general complications like infection, but specific complications are adhesions and re-rupture. Okay, now quadriga effect is specific to the flexor gestorum profundus tendon. When it is sutured in a tightened way, the fingertip reaches the palm before the other fingers. So you got a injury of FTP of ring finger, and you repair it in tight way, then it will reach finger before other fingers. All right. Okay. So, and then lumbrical plus sign, you know about that, isn't it? Yeah. So when the repair is not good, the force gets transmitted to lumbricals, and it paradoxically extends the IP joint. All right, you'll get there, but you're much better. Just try to refine your language, not technique. You know quite a bit. The organization of knowledge is good, but the wording is what you are lacking in. So you have to give easy language. You know. Yeah. Okay. All right, guys. Okay. Thank you. So this is the principle of tendon repair is core sutures, circumferential 1 centimeter grass, repair of sheath, and mobilization. All right. So who is going next?
Survival analysis.
Okay, I will do a survival analysis using either a Kaplan-Meier curve or using an actuarial method. So actuarial method normally is done at a fixed intervals, and the Kaplan-Meier curve analysis is done at the time of failure. For example, in orthopedics, it is done at the time of revision. For example, if we are talking about total hip replacement or knee replacement. And so this is, so I would take here as a Kaplan-Meier curve for an example. So it is plot, it's a time.
Which one you prefer? You're doing like using a table, or are you going to do like Kaplan-Meier?
I would prefer to use a Kaplan-Meier curve.
Why?
So this is, so number one, the reason is I can analyze at the time of failure instead of doing it at a fixed intervals. There are pros and cons on both sides, but I would prefer to use this one because I can analyze at the time of failure, because that is a significant event. If I say that's the one thing, and also the Kaplan-Meier curve has got various characteristics, and also it allows variable dates of entry and then follow-up as well. And also I can compare the two implant performances at the same time.
Okay. Okay, tell me here. So what's that? What's that?
So this is the survival analysis table. No, I'm not sure.
Yes, you are right.
Sorry, the letters are a bit small. I'm just zooming in. I'm really sorry. So, yeah, I can see the time interval on my left side, and I can see number at risk, and also I can see the number of events. I think that denotes a failure, and also the survival is calculated here. And also we are getting the confidence interval accordingly based on the sample population. So
What's confidence interval?
So the confidence interval mean is a two standard error of the mean, either side of the sample mean. So if you say 95% confidence interval, that means the true population mean lies within that. We are 95% confident that true population mean lies within that range. And usually the confidence band in normally when you draw a Kaplan-Meier curve is become wider if the sample size becomes narrower or smaller. So the each time when the failure happens, we do some mathematical calculations. So we do a number at risk, and then we see from that we will calculate percentage of failure rate. From the percentage of failure rate, we calculate percentage of success rate and the cumulative probability of failure. And from there, we will get the probability of survival. So then once we get the probability of survival, we put it on the vertical axis, and in the horizontal axis, we will draw a time. So then we will get the Kaplan-Meier curve.
Okay. Okay. So yeah, tell me what you see here. What's
so
that?
in this, so this is a nicely plotted the Kaplan-Meier curve. Is I think the time against the probability of survival. The central line, which is I'm interested in to describe to start with, in which the vertical dip, which indicates the time of failure here, this revision. The small vertical blips at the center of the horizontal line, which indicate is a right censoring. So the right censoring means it's a withdrawals, like if the patient is lost to follow-up or a death. These are all the right censoring. And and also I can see the confidence band is getting widened when the time goes up, and that means that the sample size is getting decreased. And so my left side of my curve, the numbers at risk I have, and then the right side of my curve, the number of failures and as well as the number of withdrawals.
Okay, so so what is this line? You see my arrow?
Yeah, I can see the dotted lines. This indicate the confidence band.
Okay. So what you think you did?
I think I was trying to give some structure.
Actually, you did well, but there is. I will tell you how to answer these questions.
Yeah.
So if I examine you, I will pass you. I'll give you 6.
Yeah.
But I will tell you now how you can get 8 easily with the same information you have.
Yeah.
You will not add anything, just polishing your answer.
Yeah.
Okay. So let's start again.
Yeah.
Okay. So this is okay. Survival analysis. Okay. So definition. So the outcome of intervention is plotted over time. So we didn't mention the intervention as the definition, which is the starting point of your answer. So start any answer with your definition. So what's survival analysis? Is an outcome of if intervention is plotted over time, which allows for variable dates for the of entry and different lengths of follow-up.
Yeah.
Okay, so I can like do follow-up at 2 years, 5 years, 10 years, and I can measure if there's any loss of follow-up after 2 years, 5 years, loss of follow-up of patients. So I started with 100. I end up my research with 80 patients. So I have a 20 patients loss of follow-up. I still can do a survival analysis for the prosthesis, like a new hip prosthesis or a new knee prosthesis, whatever.
Yeah.
Okay. How you can do that? Okay, there is a low equatorial life table, which is you mentioned here.
Yeah.
And time of failure. That's give you definition. So instead of saying equatorial life table method, I will say definition is a fixed intervals and times of failure. So fixed intervals represent equatorial life table method.
Yeah.
Okay. And there is a times for failure, which Kaplan-Meier.
Yeah.
Okay. Okay. How to construct a life table for joint replacement, for an example. Okay. The endpoints you have to be defined. Okay. Which is usually revision. So if your example is a new prosthesis for hip replacement, the end point to be defined here is the revision.
Yeah.
Okay.
Yeah.
And the number of joint being followed and the number of failures are determined for each year after operation. So as I told you, we're doing follow-up 2 years, 5 years, 10 years, and we'll measure the failure, or which is by definition here is a revision.
Yeah.
Okay. And for each time period, number of patient at risk, like painful hip, maybe infection, all these things, and the number of failure and the number of withdrawals. You have to record that as well. So how many patient like has been withdrawn for, sometimes you also follow up, the patient is very happy. That couldn't be counted as a failure or revision because the patient maybe didn't attend the follow-up clinic because he's very happy, very impressed, and he thinks that no need to come to see the doctor.
Yeah.
Okay.
Yeah.
So then this is the Kaplan-Meier graph. So when you see that, the way I like you to answer, number one, it's definition, outcome of intervention plotted over time. The X time. So now you will like identify everything. So let's start with the X axis and Y axis, the line in the middle, the 2 dotted lines, and after that describe the other things. You started with the sensors, with the steps.
Yeah.
So you started from the end, and then you came back to the beginning.
Yeah.
So you mentioned everything. I'm very pleased with your answer, but now this is better.
Yeah.
Give you extra mark with the same information, with the same knowledge.
Yeah.
Okay. So this is definition. Define first. I see is X, Z, whatever. Okay. I see like this is the Kaplan-Meier is outcome of intervention plotted over time. Always remember the definition.
Yeah.
Okay. The X, which is the time elapses. The Y represent the percentage of study population surviving. So how many patients now? So the 50. So by time the number decreased. Is that okay? Does it make sense? Yeah.
Yeah. I thought of y-axis. They say the probability of survival. On the vertical axis. So I'm a bit confused here. Is it outcome of intervention? Does it mean like does it denote the probability of survival?
Yes, the same thing. So the number of yeah. And there is the dotted lines. This is the confidence interval. You mentioned that. So the dotted lines are the confidence interval, and now you will describe what's in between. Okay, so increased over time due to decrease in number of patients.
Yeah.
Less reliable data towards the right, which is the right side of the plot, represent best and worst case scenario. And the upper, which was the upper dotted line, assume all lost follow-up survived, and the lower assumes they all failed.
Yeah.
And important to compare between the two prostheses can tell difference if there is no overlap. So okay.
That's really nice. Yeah, thank you.
Yeah, and there is a censored lost patients identified with a little mark subjects that are uncooperative or refuse to remain in study. So that shouldn't be considered failure.
Yeah.
Okay, so don't experience the event or die, maybe die from heart attack or anything, but not from the prosthesis.
Yeah.
So before the end of the study or they lost to follow up. They don't. The most important sentence here. They don't count that as a failure.
Yeah.
Okay. So I will try it again. So this is Kaplan-Meier number 2 definition. Number 3 is X and YZ. Number 4. Okay. Number 4 the dotted lines. Number 5 something in betweens. Okay. And the bigger one and then the smaller one.
Yeah.
Which is a small sensor.
That makes sense. Yeah.
Is that clear?
Yeah, absolutely. Thank you so much. That's
the way of answering. So you have the knowledge, but the way of answer, and you will not miss anything if you have a technique to answer these questions.
Yeah.
So sorry, can I ask a question? The vertical line is that what shows depth, or is it the transverse line which goes beyond?
No, the transverse line is the time. And the vertical
on
line,
the main axis,
and the main axis is the number. So with time, the number is increased, and you see the confidence interval here between the two dotted lines become widened because you lost a follow-up due to like many things. Number one, maybe like loss of follow-up, maybe revisions, maybe patient dying.
If it's a loss of follow-up, will it be a vertical line or a transverse line?
What you mean here? No, here.
You
no,
know.
this is the revision. So this is the steps is the revision. The sensors is the lost patient, lost follow-up. Okay, so this small sensor here.
Oh, that one. Okay, that's fine. Yeah, that's
and
what I want.
The steps is the revisions, and once
steps is the revision, and the line is the sensor.
Yeah, exactly.
Okay, thanks.
Okay. So who is the next candidate?